Hello, everybody. My name is Dr. Vladimirov. I'm reproductive endocrinologist in the Next Generation Clinic, Moscow, Russia. Today, we'll talk about preimplantation genetic testing and how can it help us to get our dream to have a child. So, what is most important thing in success, in IVF success? There's two things, embryo and uterus. And the embryo is much, much more important than uterus. I would say it's around 90%, depends from embryo, and 10% from endometrium. So, what exactly, what part or what direction in embryo is most important? First off, it's a stage of development. When we transfer embryo in uterus. About 40 years ago, we do embryo transfer on day one, or even we transfer just oocyte and sperm in a tube. Then, around 30 years ago, we start to transfer day three embryos in uterine cavity. And during the last 10 years, we start to embryo transfer on day 5 or day 6. We call this such embryo blastocyst. Second thing is the quality. Shortly, more cells contain embryo with higher quality of this embryo. And the third thing, mostly we're talking about this one, is embryo karyotype. Its karyotype is chromosomes, number of chromosomes in each embryo. All our genomes, all our genes are in chromosomes, so divided in several parts. So, stage of development. First thing, so as I told you, day 1, day 3, and day 5. Day 1, the embryo is just one or two cells. Day 3, usually it's 6, 8 cells, and day 5, 80 or 100 cells. Embryo quality. As I told you shortly, the more cells contain embryo, the higher quality. Usually they assess two things or two parts of embryo. Here you can see internal cell mass and trophectoderm, or other words, outer cells and inner cells. From outer cells, placenta is developing, and internal cell mass or inner cells, this is a place where actually fetus is developing. And blastocella is just a cavity inside the embryo. So we separately assess outer cells and inner cells. So internal cell mass, A, B, and C. A lot of cells, many cells tightly packed. B, several cells loosely grouped. And C, very few cells. And trophectoderm, the same actually. A, many cells forming a cohesive layer. B, few cells forming loose epithelium, and C, very few large cells. Chromosomes. Here you can see the male karyotype. We have 22 pair, we call it autosomes, and one sex chromosomes. Here's X and Y chromosomes. In each pair, in each chromosome pair, one chromosome is from mother and another is from father. If oocyte or sperm originates from your own clone or have abnormal number of chromosomes, so they're bad quality, and the embryo will develop, or embryo with wrong number of chromosomes. And woman age is the most important risk factor for abnormal embryo karyotype. Here you can see a percentage of embryo with wrong number of chromosomes. We call it aneuploidy. Here, as you take a look, till up to the age of 35, we have 30, 40 abnormal embryos. So embryos containing a wrong number of chromosomes. And after the age of 35, there is steep increase percentage of abnormal embryos. In other words, there is prevalence of Down syndrome by mother's age. Down syndrome is a wrong number of chromosomes. We have trisomy, or we have 3 chromosomes instead of 2 in pair 21. So here you can see after the age of 35, there is steep increase of prevalence of Down syndrome. In IVF, there is no more then 60% of blastocysts has normal karyotype. So it depends largely from the age, and a lot of embryos has a wrong number of chromosomes. If we transfer the embryo, which has the wrong number of chromosomes, three things can happen. First one, I would say safest, no pregnancy. Embryo just stopped inside the uterine cavity and we got menstruation, that's all. Second thing, miscarriage. So pregnancy starts to develop. Usually it stops before 12 weeks of pregnancy. And it's just, we call it mispregnancy, misabortion, so no symptoms, the embryo just stops. Or we have a bleeding, so miscarriage. And the third thing, the worst case scenario is a newborn with chromosome pathology, like with Down syndrome. Using prenatal screening, we can prevent delivery of this sick child, but if we find out this pathology during pregnancy, the only way is to pregnancy termination. So the problem, the IVF outcome with aneuploid embryos are bad. Solution, the transfer on the aneuploid embryo. Before we start talk about how exactly we can solve this problem, I would like to talk about such thing like mosaicism. Mosaicism is a thing when one embryo contains different cells, with cells different number of chromosomes. Some of them have normal number of chromosomes and some have abnormal number of chromosomes. On this picture, you can see what stage of two cells embryo error happens. And then these wrong bad cells, the cells with wrong number of chromosomes, start to divide and produce the clone with abnormal cells. 8 cells, it's usually day 3, and blastocysts day 5, 6. Here you can see the circles, the embryo of these 8 cells. Some of them are normal, green one, and 4. And 4 red one, it's wrong number of chromosomes. So what happens next during development? Normal cells start to divide, normal mitosis, so 2 cells. There is sometimes bad cells with abnormal number of chromosomes self-correct. So we have a normal number of chromosomes. Most of these cells just degrade, we call it apoptosis. It just disappear, and some just stay. They not divide, just stay. And here on lower part of the slide, you see the blastocyst, the embryo on 5th or 6th day of development. So bad and green is good one. So how often this happens with mosaicism? On this picture, blue one is aneuploid embryos, orange is aneuploid, and gray as mosaicism. So as you can see, it's around 10%. It's almost independent from the age. The normal embryos are decreasing and abnormal are increasing, but this one almost the same. Is picture the aneuploid embryo, so internal cell mass, trophectoderm, abnormal cells. He is aneuploid, so all the cells have abnormal karyotype, internal cell mass, and outer cells, trophectoderm. And here, mosaic embryo, so the mix normal and abnormal cells. There's normal, abnormal, and inside as well. So some few words about history, because the idea to transform the normal embryos is long-lasting. So before year 2010, we didn't have a good enough tools, instruments to do this. Why? Because we do biopsy on day 3, and in day 3, a lot of mosaic embryos, up to 60%. So at least half of embryos has mosaicism. We took only one cell for study, and due to mosaicism, it was hard to say what about other cells which are rested in the embryos. Not all chromosomes, so now we test all chromosomes, but before year 2010, we test 5, 7, 11 chromosomes, never all chromosomes. And very important thing, because the embryo contains only 6 to 8 cells. One cell, it's a lot for this embryo, and it was excessive trauma for embryo. So up to 22% of general cell mass was extruded from the embryos. So what we got? We got decreasing IVF success because of too much trauma, because we transfer embryos with unknown status for half of chromosomes, and we didn't know about the rest chromosomes. After year 2010, we start to do biopsy on day 5-6, as a blastocyst stage. In this stage, mosaicism is much lower, about 10%. We take 4 cells for study, so even in mosaicism, we can assess much precisely, and we start to study all chromosomes. So what we have now, increased IVF success because of safe biopsy. 4 cells chromosomes in case an embryo contains 80 or 100 chromosomes. It's not much. So it's safer. Because we take 4 or 6 cells, less in mosaicism influence, and we tested all chromosomes. So this study was done in 2013 about safety of biopsy. So in this study, 2 embryos were transferred in uterine cavity. One of these embryos was biopsied, and our one is not. The transfer was done on day 3 and day 5. After delivery, newborn DNA analysis was done and matched the biopsy sample from the embryo. If matched, it means biopsy embryo is implanted and gives a pregnancy. If not, so it's intact embryo. And they get next results. So in case a biopsy was done on day 3, they get 30% of pregnancy. In case of biopsy, and without biopsy, 50%. But in case of biopsy on day 5, 51% in case of biopsy, and no biopsy, 54%. So almost from statistical point of view, there is no decrease. And what we got at the end. So after PGS, there is a table which contains results of embryo transfer for calculating for every embryo. So green one is a pregnancy, and blue one is without PGS. Green one pregnancy with PGS, and blue one without PGS. As you can see, at the age of 35, after embryo transfer without PGS, results was 41, and after PGS, 57. And it started to decrease in case of without PGS along their mother age. So it's after age of 42, it's just 4%. But if you transfer embryo after PGS or PGT, it's almost the same. In our study, and it's calculated for pregnancy as well, but I would like to talk about miscarriage rate. And this study, it was shown what after transfer embryos, after PGS, we dramatically decrease the rate of miscarriage. So what is the workflow about PGT, PGS? First, we do a standard ovarian stimulation. We took a womb pickup, so take oocyte from ovaries. Then we cultivate, so do a cultivation or received embryos up to day 5-6, so we have blastocysts. Then we do biopsy. Using biopsy, took a few cells from outer cells. Then freeze embryo, so it stay in the clinic. But these cells we took for analysis, we sent to genetic lab. Then we get results, and if it's good, we do embryo transfer. So mostly frequently asked questions: is embryo biopsy safe? Can we trust PGT-A results? Is it possible to discard good quality embryos because of wrong results? How PGT-A exactly changes in fertility treatment with artificial reproductive technology, indication for PGT-A, and PGT-A disadvantage and problems. We talked about this study about safety. As you can just remind you, if you do biopsy on day 5, it's safe. Now a study addressing the worries about transfer and wasted a good quality embryo because of wrong results. Here was 400 patients, 484 single frozen blastocyst transfer. It was a first IVF, no recurrent pregnancy loss, normal ovarian reserve, so yeah, body mass index less than 35. All blastocyst was biopsied. Single best morphologically blastocyst transferred before genetic analysis. Preimplantation genetic testing for aneuploidy was performed after clinical outcome was determined. So if pregnancy happens, okay, we do testing. If there is miscarriage, we do testing. And deliver, we give a birth, so we do testing. And clinical outcomes was compared to PGT-A results to calculate predictive value of PGT-A and aneuploidy diagnosis. So the error PGT-A and aneuploidy diagnosis clinical error was 0. So no normal embryos, so no abnormal embryos give a good result. There's no difference in sustained implantation before the study group and the age-matched control group, where biopsy was not performed. So about the same actually topic about safety, or can be wasted, can be trust. Here is a study, their cells was taken from internal cell mass and from external. So we call it trifactor agronomy. And compare, we call it concordance. 29 embryos, most of them, 25, has the same cells. Good one out cells, a good one in cells. Bad one outer cells, and bad one inside. Mosaic cells, outer cells in trifactor agronomy, and mosaic cells, the same internal cell. But here, type 4 and 5, there is no concordance, so different results. Outer cells are normal, so aneuploid, but in inner cell mass have mosaic cells. Some of them, some cells have their own number of chromosomes. Here, mosaic cells in trifactor agronomy and normal inner cell mass. And here's our situation. So outer cells, trifactor agronomy, has mosaic cells, and other cells, or inner cells, are wrong number of chromosomes. And in theory, can happen these things. Outer cells or trifactor agronomy can have normal aneuploid, but inner cell mass can contain a round number of cells with round number of chromosomes. And different situations mirror. So aneuploid outer cells and aneuploid inner cells. We didn't see in practice. We didn't see it in practice, but in theory, it can happen. So how exactly it changes infertility treatment in IVF? Less time to pregnancy, because we do not transfer embryos with abnormal karyotype. Less miscarriages, because of the same reason. Less wasted time to solve medical problems because of them. For example, in case of miscarriage, there is can be some complications, like infection, for example. IVF is safer because of transfer embryos, tested embryos with good number of chromosomes. We can transfer just one embryo and have very good results. So we get very low risk of multiple pregnancy, about 1.5%, because even one embryo can divide you the twins. Very low risk of hyperstimulation because there is no fresh embryo transfer. And much more effective IVF. I show you this picture. If we do embryo transfer after we did PGT testing, so we have much better results. Indication for PGT-A. Indication remains heavily debated in clinical practice. The following indication for its use have been reported. Advanced maternal age, This is age more than 35. Usually talk about this. Recurrent implantation failure. So do several embryo transfer, like 3 or 4 good quality embryos and no pregnancy. Recurrent miscarriage. There is a lot of discussion actually about, because most cases have other problems, not wrong number of chromosomes or aneuploidy embryos, and severe male factor. Problems and disadvantage. Very high requirement for IVF lab, because we need very good process in good quality cultivation of embryo. The embryos have to be very qualified, highly qualified for vitrification, so embryo freezing. The clinic need to have very high percentage of PGT-A IVF program, because the embryos need practice all the time. So manual skills. One of the big problem still mosaic embryos. So as I told you, it's about 10% of all embryos, because we're still scared to discard potential viable embryo. During the last 5 years, we changed our attitude to mosaic embryos. For it used to consider like aneuploid, but now it's we consider more like euploid. So it's not just black and white, but many shades of gray. Thank you. Bye.